Okay, so thanks very much. It's a great honor to be here, and it's a great meeting as always. I will try and catch up significantly, so forgive me if we go rather rapidly through some of our slides. We're just going to talk about our experience of MIPS technique and how we integrate it with our approach to brain tumor patients. And I thought we'd pay respect to the first parafascicular surgeon, who was obviously Phineas Gage, and not to be outdone. This is a patient who presented on my on-call 2 weeks ago, who is a true genius because he's managed to cross the midline and bisect the corticospinal tract and then go up and bisect the motor representation. So he presented with epistaxis to his local hospital, was sent home with tranexamic acid, and then came back with a motor weakness. And so if we go to the next slide, you can see that we, and I've got some rather gruesome pictures on my phone if anybody wants to have a look, but we managed to remove the pencil that he'd inserted. And you can see from the TMS map how he'd bisected the motor representation. And we rehabilitated him and are currently doing that with navigated NTMS using the stroke protocol. And we'll talk about this in terms of how we work with our tumor patients. So we started looking, and we've been doing MIPS now for quite some time. We've done well over 3 figures. And we've started looking at this concept of trying to produce standard approaches to different areas. So we've come across this cross concept where we use the white matter fibers, and particularly the projection and the association fibers, to define this cross and this anterior-posterior boundary, and most importantly, a medial and lateral boundary. And what we've found is that zone 1 and 4 are particularly amenable to a MIPS technique. Zone 3, Jose will talk about a bit tomorrow, because we've been quite heretical with that approach and have actually started doing a transgyral approach with MIPS, because we've actually got data to show that it produces less ischemic injury, but we'll discuss that tomorrow. So as you can see, the zones that we talk about, and zones 1 and 3 have really become the workhorses for us in terms of MIPS. But zones 1 and 3, particularly zone 1, is the zone that's most associated with a preoperative deficit, either speech or motor, given its eloquence. Just to illustrate where this has come from, this is one of our earlier papers where we illustrated removing a deep-seated tumor near eloquence. And what we've done in this is with the myriad, we're using short track because we're a stealth-based system. We're navigating the myriad, but we've also electrified it so that we're using it as a monopolar stimulator. So that then increases the utility of that tool and allows you to really get more bang for your buck. We put strips in, so we've got a strip here in for motor and optical, so interhemispheric, and this is a sort of a standard approach. So we make slightly bigger craniotomies than you might traditionally do with a MIPS technique to allow for monitoring, because we resect functional boundaries, and we do awakes with MIPS as well. We've started using MIPS for butterfly gliomas. So this is something that from our service where we talked about reappraising butterfly gliomas. And this is a patient, a 42-year-old male, who presented with butterfly glioma. In traditional European practice, this patient would probably get a biopsy given his age to look for methylation status, but nothing more. We were able to perform a pretty reasonable debulking for him. And as you can see, he went home at day 5 with no deficits, and we were able to offer him full stup, which I don't think he would have got through without a debulking approach. And you can see how we've got to that with the MIPS approach. So our surgical experience, 4 and 3 are inverted, so it should be 29 for, anyway. Bottom line is that 1 and 4 are our 2 big workhorses, 1 more than 4, but those are the 2. 2 and 3, much less so. Jose will touch upon zone 3 tomorrow. And as I've said, we don't do a transsulcal for zone 3. We tend to do a transgyral, even with a MIPS technique. Zone 1, these are the patients who present with a preoperative deficit by and large. These are the patients who present with a motor or a speech deficit or both. These are patients who in traditional European practice would get a biopsy or nothing. And we've been able to, with the MIPS technique, offer them resection. And we've published data to show that our biopsy rate has completely gone off a cliff. It's completely dropped. If we can do a biopsy, we can generally approach the tumor. So neurological deterioration does occur, obviously. And in zone 1, as you can see here, motor deterioration tends to predominate, and language. And in zone 4, it tends to be visual deterioration. Visual deterioration obviously is much more well tolerated in the context of malignant disease. A patient will readily surrender their license for the greater resection that they may get. Again, just comparing zone 1 and 4, which are workhorses. So as you can see, it's zone 1 where we get a motor and we get a speech deficit postoperatively. Zone 4 tends to be visual. So final thoughts on this. MIPS is very good for zones 1 and 4. It is the approach, however, that's associated with patients who have the greatest preoperative deficit. And these patients, particularly zone 1, can get postoperative deficits because these are highly eloquent tumors, and patients who traditionally would be offered either best supportive care or a biopsy at most in the context of European practice at least. So then how do we use a MIPS technique and think about that in terms of rehabilitation? So this is one of our early examples where this is a patient with a metastatic tumor. Tumor went down to the sylvian fissure, and you can see the resection that we did with the MIPS technique, and you can see the ICG injection at the end was quite nice. There wasn't any obvious ischemia, but as I often tell the residents, if you see the sylvian fissure during a tumor resection, beware. And a day later, I think the patient developed a stroke, as you can see. And we then proceeded to, using a stroke protocol, rehabilitate the patient using an NTMS protocol. And what you can see is how the amplitudes in both upper and lower limb returned, not to normal, but returned to good function using an NTMS protocol. And the latencies bounced back quite impressively as well. And you can see on this map that we produced, preoperatively, immediately postoperatively, it's difficult to get any TMS representation for the motor cortex. And postoperatively, both for upper and lower limb, you can see those dots return. And the small homunculus at the bottom just shows you that immediately post-op day 1, patient was 2/5 in the upper limb, 0/5 in the lower limb, and at day 7 was back to 5/5 in both. We then started to investigate the actual tractography postoperatively. And what we could see was you could actually see where the tract was damaged, and you could see that it was exactly at the point where the stroke was demonstrated on the anatomical imaging. And so that gave us confidence to start thinking about consciously incurring a deficit, knowing that we could potentially recover it, and in patients who might not have surgery otherwise. And this is a 78-year-old lady with metastatic melanoma. You can see her metastases, and we deliberately decided that we would go for an awake, and we would transgress the transvesicular approach. We would go across the frontostriatal tract with the tubular retractor. So this is the post-op scan. You can see the tractography has clearly shown that we have deliberately done some damage here, but we've achieved a complete resection. And before we showed the NTMS, I don't know how many of you are aware of TMS in stroke, but basically the idea is that you stimulate both hemispheres, but particularly the contralateral unaffected hemisphere, which in a stroke becomes overexcited and inhibits via the corpus callosum activity in the recovering brain. And there's good literature from the ischemic stroke literature about this. So Jose, do you want to play these videos? So this is the lady at day 1. And you can see it's bizarre, but she's stimulating the same hemisphere as the side of the weakness, and that's because we're inhibiting the contralateral hemisphere. That's her at day 3. And then we should be able to play a video of her using the affected hand to eat breakfast. And at day 10, she walks home. And she's being supported with the hand that was unaffected. So the affected hand is the one that she's currently pointing with. Thank you. So we then published a series of 7 patients in tumors in highly eloquent areas where we knew that we would incur a deficit, but by integrating a MIPS approach with NTMS and tractography, we felt that we could rehabilitate them very aggressively. And what we found, to cut a long story short, was that 2 patients recovered to their preoperative functional status and 3 patients actually improved to PS0. So if we go to the next slide, you can see how eloquent those tumors are in terms of their location. And those are the sort of some representative axial images pre and post-op. This is some of the data to illustrate the recovery that occurs, the post-op deficit, and then the recovery that we get. Some data on MRC grading for the upper limb. You can see that the improvement that occurs after the NTMS, same for the lower limb. And this is a slide that I always like to show because this is versus an observation group. We didn't get NTMS, and I'm very grateful to my neurovascular colleagues for supplying this very large neurovascular cohort of patients with a deficit. Lower limb observation. Again, we're not saying that this allows us to be blasé. We're not saying that this allows us to ignore what we do intraoperatively. Okay, and we've got data to show that if the MEPs drop during the procedure, the recovery will not be as good as you might predict. So even though you may get, and you'll all be familiar with this, where the MEPs drop, but or the MEPs stay stable, sorry, and the patient then has a deficit which then recovers. This is, if you lose the MEPs or the MEPs drop, you can salvage it with NTMS, but it will never be as good. So we're absolutely not blasé about this. This is a patient, we always present this patient because fortunately, touch wood, we've only had this one stroke that really was dramatic. It's a patient where we caught the ACA branch, and you can see the stroke. You would expect from that scan the upper limb to improve. That's fine. But the patient's lower limb also improved significantly with a navigated TMS. And again, I'd point out to you that this, in the context of European practice, is a patient who almost certainly wouldn't be offered surgery. So this is the MIPS Connect, and so I should declare that we have received a grant from NICO to look at this. And just if anybody from NICO's here, we said that we'd get to 20 patients in 18 months. We've got to 15 in 6 months, so we should have some data for you pretty soon. This is a case, eloquent tumor, IFOF and arcuate pre and post, and you can see that the IFOF's bulked up and the arcuate has narrowed down after the resection. When we look at that in terms of following the tract along its path, you can actually see the IFOF, better representation. The arcuate, you can see that it's less represented. And then when we look at this in terms of connectomics, so you can see the posterior segment of the arcuate fasciculus has really narrowed down in terms of its connectome. You're not following the arcuate with connectomics, but you get my point. Whereas the IFOF is, or the areas that we think subserve the IFOF, has greatly expanded post-operatively to really connect to a much larger area as you would hope and expect. This is the first 3 patients, and what we can see is that the IFOF volumes are preserved in 2 out of 3 patients. The actual fat, or the functional anisotropy, is completely preserved, and that's being replicated in the other patients that we've so far collected. So in summary, we're integrating MIPS into an approach that personalizes surgery for the patient, allows us to offer surgery to patients who traditionally wouldn't be offered surgery, surgery in highly eloquent subcortical locations, and then integrating that with navigated NTMS to produce rapid rehabilitation to then allow patients to recover more rapidly from their surgery. And we're trying to join that up with some of the anatomical data. So I'm sorry that's been a bit of a rush, but I have made up 5 minutes for you, so I'll take that. And I just want to say, you know, as clinical director, I just want to, this is the neuro-oncology service, and, you know, it's a great team. And this is definitely the work of a huge team of people who are incredibly dedicated to their patients. And, you know, I'd extend that team to Nico, who've been with us on this journey all the way. So thank you very much.
Thanks so much. Time for one question? Yeah, Annalie?
So I just wanted to ask you if you've experienced something I have where you cannulate and you're working near the motor strip and you get a change in MEPs and then you decannulate, it
Yeah.
comes back. Um, can you just talk a little bit about that situation and trusting, that it's due to the shift that you created, and just talk about how you deal with that when you know that it's a change in your potentials from the cannulation.
Yeah. So, I mean, the reality is that you have to have. Oh, yeah, of course. Sorry. Yeah, yeah. My apologies. So you have to have basically confidence that your trajectory is correct. You have to have confidence in the fact that you know that this is going to get better if you're on tumor and you're on location. And also, I'm not the world's greatest surgeon, but I'm not so bad that I'm going to transgress across something on the cannulation. It's going to be pressure. So I think it's about having that degree of confidence, and it's about what the team tell you, the information that you're getting back from your intraoperative neurophysiology as well. But it's the confidence of having done a lot of these, you know that it's going to come back, and you might just give it a few minutes, stop, pause. It's a bit like when you resect an intramedullary spinal tumor. The MEPs will fall, and if you let it recover, irrigate a little bit, it will come back up. So I think it's that sort of surgical experience that allows you to get over that. But yeah, it happens, definitely happens. Okay, thank you very much.